Is better. Assalamu alaikum, and thank you for the organizers for inviting me. I'm going to deviate a little bit from the topic in the program. I'm going to talk about the controversies in the management of thoracolumbar trauma, so it fits with the rest of the speakers. Um, yeah. Okay, so the slides are not changing here. I have no conflict of interest. Right, I have a few limitations to my talk. Firstly, my talk will only be addressed on adult patients. I will only be able to address a few topics because of the interest in time. Also, because of the interest of time, I am limiting my references to a limit because I mean this talk can go on for hours, and of course it will only be a 10-minute talk. I will, being a neurosurgeon, I will put in my personal views and preferences, which may not be globally applicable, not just for each individual center, but also for each individual surgeon. So the first controversy that comes to mind is the classification, and we read a lot of classification system for thoracolumbar trauma. We tend to use the TLICS, and this is what is frequently told to us by the people appearing in the examination. So it seems that for neurosurgeons around the country, this is the most frequently used classification system. It is easy to use, and it also has a row in the bottom which sort of guides a surgeon to operative and non-operative management. But if you look at the literature, it's not the best classification system. It does not have good inter-observer variability. It's not duplicable, and there are lots of problems with that. And on the other hand, the AO spine classification for thoracolumbar fractures seem to fit the bill better than the TLICS classification system. And just recently, there's been a consensus on this that the best classification system for thoracolumbar fractures is still the AO spine classification. The second controversy I'm going to talk about is the role of steroids. And to be honest, there's not much controversy in that. We all know that the NASA's trials, we all know what came out of it. However, we still see a lot of patients being managed around the country with steroids in the initial phase. So just a recap, this is the famous, the hype cycle that has been introduced by innovators, the company Gartner, and is applicable to a lot of new innovations that is introduced in the market, be it implants, be it technology. And this is what typically happens whenever something is introduced. Everybody starts using it, and then the data starts coming in, and the use slowly fades. And so this has been the trend with the use of steroids in spinal cord injuries as well. The use was immense at the time that the first NASA's paper was published, and then the post hoc analysis was published, and the commentaries came in, and then discussions and debates came up, and all of a sudden the use went down. We now see some use around the globe, but there have been a number of studies where the surgeons were asked, do you use steroids or not? And interestingly, most surgeons prescribe it, but most surgeons believe that it does not work. So the data that we have right now, if I am to summarize it, the steroids for spinal cord injury have questionable benefits. They have definite side effects. And still the data is unclear with regards to the dose, the duration, and the type of steroids that are to be administered. My next controversy I'm going to talk about is non-surgical versus surgical management. When I started my training, I was a very proponent of managing spinal injury without surgery, especially patients with complete spinal injury, because we found out at our centers that patients with complete injury tend to have worse complications, higher cost, and the outcomes were no different. In fact, our outcomes were worse than patients who were managed with surgery, without surgery. So based on that, we recommended that for patients with complete injury, we should not be operating. However, we faced a lot of wrath for that paper. Also, when I look back at my study, very few patients that I found were actually for thoracolumbar fractures. It worked well for cervical spine injuries, but not so well for thoracolumbar fractures. By and large, the consensus is this: regardless of the extent of injury, regardless of the neurological status, patients with unstable spine should be fixed. Now the question is when to fix it and how to fix it. We'll talk about it later. But generally, there's one specific type of spinal fracture on which there's more of a controversy and whether they should be fixed or not, and that is the burst fracture. And there are several trials, several randomized controlled trials that have looked on it, and they're not very high-powered trial or very good randomization, but the consensus generally is that operative management of thoracolumbar burst fractures without deficits may improve kyphosis, but does not appear to improve pain or function at an average of 4 years after fixation. So the results are the same, whether you fix them or not fix them. Of course, as clinicians managing these patients on an individual basis, in these circumstances, it's up to us on how we would like to tailor our decision based on that patient and the circumstances. But that's what the data says so far. Now, the timing of surgery for thoracolumbar fractures. So there are lots of studies on this as well. And this is a recent systematic review which has really looked at how the timing affects the outcome of these patients. But if I'm to summarize, it is preferable that these patients, so if you have a thoracolumbar fracture that needs to be fixed, it's preferable that you do it within the first 72 hours. However, if the patient has additional injuries or the patient is unstable, it's safe to wait beyond 72 hours. The earlier papers all talked about improved outcomes if you fix early, that is within 72 hours. However, there are two recent papers published in the last 5 years that have talked about the second head phenomena, and that is, patient is just coming out of a physiological injury and you subject them to another physiological injury, and that's what they call the second hit. And they showed that the outcomes in these patients, the medical complications in these patients were higher. So if you do proceed with fixation within the first 72 hours, there's a small risk that these patients will have a higher risk of medical complications. So again, the data isn't clear, and the decision rests on the operating physician, operating surgeon. That's one of the two papers that talked about the double hit. The next list of controversies I'm going to talk about is surgical approaches plus. This includes not just surgical approaches, but other factors that we deal with. So there's a lot of debate on whether these fractures should be fixed from the back, from the front, both from the front or the back. There's immense amount of data that shows that posterior only fixation is good enough for most thoracolumbar fractures. In my personal practice in the last 6 years, I have not had to do a posterior fixation from the front. I do it almost always, now I do it always from the back. And I think all sorts of fractures can be reduced from the back. It saves time, it's quick, it's less traumatic, especially for patients with systemic injuries. So it works well. There's a controversy with regards to using short segment versus long segment fixation. Again, the data clearly shows that there's no difference for certain types of patients, but with patients with increased scaphoidal deformity, you would like to do a long segment fixation. But if there's not a lot of scaphoidal deformity, you can go ahead with a short segment fixation. There's some debate about using the fracture segment for fixation. As you can see from this patient, I try to put in screws in the fracture segment whenever I can. The recent data shows that you can. In fact, at times, even if you are 3 millimeter, 30 millimeter length pedicle screw, that's good enough, because as long as you have purchase of the pedicles, that still provides some stability. So whenever you can use the fracture fragment, it's preferable. But if there's a fractured vertebral body in front of the fracture, and there's a risk that your screw placement might push the fracture fragment onto the retroperitoneum, it's better not to do it. So the data is divided, but it has to be individualized according to each patient. MIS versus open, not a lot of papers, but it seems that MIS should have better outcomes in these sort of patients for a lot of reasons, and some of these reasons I'll allude to further on. Polyaxial versus monoaxial, again, there's not a lot of difference, but whenever there's a correction that has to be made, monoaxial screws are probably better. I always use polyaxial screws. And then there's a lot of literature about the length and the diameter of the screws. Again, the fundamental principles are that the screw length should not be less than half the breadth of the vertebral body. Longer length screws have been shown in some studies to offer greater stability, but there's no comparison, so we can't be sure that this is it. And these are mostly cadaveric studies with small sample sizes. The principles are you need to have a length at least more than half the depth of the diameter of the vertebral body. If it goes up to 2/3, that's even better. Diameter of the screws, there are several studies also on cadavers which have talked about this, and generally a larger diameter screw offers better stability. My personal practice is I would not use a less than 6.5 millimeter diameter screw in a thoracolumbar fracture, even in the thoracic spine. Again, lots of debate about whether these fractures should be fused or not. The data is conclusive here. Adding additional fusion material does not add to fusion in thoracolumbar fractures. Remember from orthopedic principles that this is an internal fixation. It does not require bone grafts. The fracture, as long as you're able to stabilize the fracture, immobilize it, the fracture will fuse itself. But if there's additional bone loss, it might be worth it to put in some bone fragments. So as far as the data is concerned, the literature is concerned, we don't need to fuse these fractures, we only need to fix them. Initial studies talked about using the different types of grafts and BMP. The choice of grafts does not help because now we know that fusion does not add to the stability. Similarly, BMP does not help. In fact, there's some studies which talked about BMP offering better fusion. However, it's not cost effective, even from the standards of the West. And precisely for this reason, that the type of grafts and fusion does not add to the stability, that we feel that MIS would be a superior choice for thoracolumbar fractures than doing it open. Antibiotics, I mean, there's tons of data that shows that antibiotics in closed clean surgeries beyond the first 24 hours do not add to any prevention of infections. But we keep seeing these patients put on long durations of antibiotics with broad spectrum antibiotics. But there is inconclusive data, irrefutable evidence that antibiotic prophylaxis beyond 24 hours of a single dose covering gram-positive staph will not offer additional benefit to these patients, as long as these are clean surgeries. And that was my last slide. Thank you.